the next speaker to you is Joël Daems. He's from the Belgian Social Insurance, RIZIV-INAMI. He is one of the players that was mentioned by Claudia. He's working since 2010 in the public service department of RIZIV-INAMI. He's an HTA expert, member of the task force vaccination in Belgium, and coordinator of the HTA task force for COVID medicines. So he's a medical doctor by background, and we're really pleased that you can join today. The floor is yours.
Thank you. I hope you can all see the presentation by now, because...
Very well.
Okay,
and again, for all of you, the speaker slides can be made bigger if you just reduce the picture of Joël, for instance. Just push your bio with your mouse, for instance. Thank you.
So thank you for the invitation. As Claudia said, the pandemic situation of COVID-19 has pushed very much the limits of health technology assessment of the governments, of health expenditure on vaccines, on potential drugs to treat those patients. And we are all hoping that with Omicron that the pandemic situation could evolve to a more endemic situation where we can evolve to some kind of flu-like situation with COVID popping up during winter, and we have only the protection needed of patients with a fragile immunosuppressive system, immunologic system. So, but a major point regarding the payer's perspective is that reimbursement of drug therapies is still a national competence in a European level. So, and that is putting some pressure and some frictions between the different actions which were done during this pandemic situation. As you all know, regarding the vaccines, as Claudia mentioned, it was quite important at that time to really play volume, and the European Commission was quite proactive in having those advanced purchase agreements with the different vaccine companies or the potential vaccine companies on negotiating on pricing, on volumes of the vaccines which were in development early on. So every member state had the option to opt in for certain volumes which were available, or which could be available once the production of those vaccines could be guaranteed, and of course once EMA had granted the conditional marketing authorization conferring Article 14A for a public health emergency, as in the case of a pandemic situation. And we all know that in the beginning there was quite some fuss regarding a lack of volumes, all the problems with the AstraZeneca vaccine regarding side effects, vaccines which and the selection of patients. So, but that's one thing, the vaccines which is moving on, and I will touch upon it later on in the presentation. The situation we are facing now. As Claudia mentioned, also we have the monoclonal antibodies and the antiviral compounds which were popping up lately. The European Commission is also supporting the R&D and clinical trials and scanning for candidate therapeutics. There's a whole program funding those initiatives, and EMA is also giving either conditional marketing authorization or is reviewing does the rolling reviews of those compounds. And luckily for some compounds there is a classical marketing authorization submitted at the moment being for molnupiravir and the Paxlovid and the baricitinib, for example. But at the moment being, each member state still has to negotiate with the pharmaceutical companies on in bilateral agreements on pricing and volumes. And there is one very tricky point which I will touch on later on. And then there is also the more classical way of extended indications by the EMA, as has been done for tocilizumab and anakinra at the moment being. As I said earlier, for the vaccines, the advanced purchase programs, It's all a very confidential way of working because from a national payer perspective, we don't have any clue, at least some do, on the exact pricing and the volumes and the terms and conditions which were put in by the industry in those contracts. We also don't have any clue about relative effectiveness, and if this relative effectiveness is also reflected in the pricing between the different vaccines. We all knew that from data emerging in media or by leakages everywhere, that pricing of the AstraZeneca vaccine, for example, was much lower than the RNA vaccines of Pfizer and Moderna, for example. But we don't know anything about is the relative effectiveness, if that was transposed in the relative prices paid for those vaccines. We also don't know because the vaccines we are still currently using today aren't the best ones for the biological evolution of the virus since then. We all know that Omicron is quite effective in escaping either natural immunity or vaccine-induced immunity. So for an HTA basis, it would be a very logical assumption to say, okay, if your compound is less effective, it must have a repercussion on the price we are paying for it. So we don't have any clue if that is happening, yes or no. And for the moment being, it's still in the conditional marketing authorization. There is for none of those vaccines a classical marketing authorization or HTA procedure ongoing, which means that we also are lacking very solid data on relative effectiveness, on adverse event profiles, and for the future, if hoping so, we would evolve to an endemic situation. Which vaccines would be the most preferable for those fragile patients, which will most likely have to benefit from vaccination on a yearly basis for the next couple of years. Now, moving to monoclonal antibodies and antiviral compounds, as Claudia also mentioned, it is quite difficult to have real data. There is a lot of marketing fuss going around, a lot of media attention, a lot of relative percentages, which are really stunning if you see them. 89% reduction of hospitalization. It's really looking very fine, but if you look into the data and if you're doing some kind of calculations on number needed to treat, those stunning percentages are less stunning in the number needed to treat. And then if you have to take into account the confidence in intervals of those results, it's even less attractive. And if on top of that you are looking at the patients which were included in those trials, non-vaccinated, the only major risk factor being obesity, very few, if any, patients with underlying immune diseases, those results are quite puzzling. And as I said earlier, based on the media hype, the marketing fuss generated by the companies, the little thread between brackets that there is not a lot product available. You have to be fast for a country if you do have a guarantee on a certain volume. So there's putting a lot of pressure on local governments to have some kind of early discussions, agreements with the industry on certain volumes, but it's quite difficult based on the available data to know what will be the real clinical value of those compounds, what will be the ideal population where those products can be put in, because based on the limited available data we have at the moment being, it's very hard, not to say quite impossible, to have a guidance. And in every member state there are scientific task forces put together in order to assess all those data, in order to guide the political level on which compounds could be in a certain setting attractive or could help to protect vulnerable patients. For example, patients, transplanted patients having B-cell depleting chemotherapy, for example. We all know they have a very few, if any, response to the vaccination. So that would be the most optimal patients to have some kind of additional layer of protection, either by monoclonal antibodies or by antiviral compounds. But at the moment being, we don't have any clue on the effectiveness of those compounds in those patients. And as Claudia mentioned also, given the biological evolution of COVID-19, we all know that the monoclonal antibodies, the effectiveness on binding COVID-19 is quite diminished. For the moment being, there is data from lab results that Omicron is escaping almost all of those monoclonal antibodies available. There is still some effectiveness proven for sotrovimab. For the Evershed, it's still a big question mark because one of the monoclonals in that mixed compound is certainly not effective anymore. The other one has a factor 10 to 100 in IC50. So it's we don't have any clinical data on the real effectiveness. And as Claudia mentioned also, there is a difference between the intravenous antibodies like sotrovimab and the intramuscular antibodies like Evershed, because certainly in those vulnerable patient populations, it's quite key to keep them as far as possible at COVID infection. So you don't want to have those patients in daycare clinic to have an administration of a monoclonal antibody. And if you could give them something in intramuscular by the general practitioner, it would be much safer for those patients not to have to a transportation to an hospital setting. So that means that for the moment being, we are more or less in the same situation for the vaccines. HTA organizations don't really have the data needed. It's very hard to obtain clinical results. The clinical results we can obtain as those published or media reports with a very small data sets in it, but the real clinical reports, there are some reports available at EMA level for those compounds who have a marketing authorization application or in rolling review. But even in the rolling review, the clinical trials which were done, which were analyzed, are more in at interim reporting. So long-term data after one month, for example, for the antiviral compounds isn't available neither. There isn't any information about COVID variants information, and there isn't any information about special patient subpopulations. So that's something which is really urging, and I think if there is one key message that we should go back to normal as soon as possible. Meaning that normal HTA procedures on pricing and transparency and definition of relative effectiveness and definition of willingness to pay, because now we have a definition of willingness to pay, first in, first served, and at a certain confidential price level. But during an HTA procedure, you are really defining the willingness to pay. You are calculating ISO levels. You are seeing which compound is worth the money, which isn't worth the money, and which would be the ideal patients in which those compounds can be set in. So I think from a European, from a political level, from EMA should really be urging the companies to go back to normal as soon as possible. Certainly, if hoped for, we would evolve to an endemic situation once the fifth wave of Omicron is going down. And based on the information of virologists, they are, between brackets, quite optimistic that towards spring and summer, we could be moving to a more endemic situation if there isn't any other variant popping up, which would be more difficult to handle. And then we could start really based if EMA has granted the marketing authorization to have a real clinical evaluation on efficacy. and that would have a clear view on the budgetary implications. But for the moment being, I think any HTA organization has a clear view of the whole budget impact on the healthcare expenditure of the vaccines given today, of the clinical compounds which were used in those bilateral contracts. And I think that that's quite key because, okay, we were in a crisis situation during the pandemic situation, but I think the key message still be that we have to evolve to a normal situation as soon as possible, because for industry, this kind of situation is really some kind of nirvana situation for them, because they have control of all data, they have control of the terms and conditions in those contracts. There isn't any outside HTA control on the data provided, and so they are playing the game of marketing, which they know very well, on triggering and pulling on different strings in the political system to really create some kind of need of desire for the national governments to opt in those kind of contracts. And I think oops, that was the last one. I think it should be very key that also for physicians, which are naturally very caring about their patients and want the most optimal protection available, that as HTA organizations, we can say then, okay, that kind of compound, that kind of clinical situation is ideal for that compound, or it isn't ideal for that compound, and that we can, as HTA organizations, really direct once again the available money where it is really needed, and that we can have an assurance that every compound, every vaccine, every monoclonal antibody which will be reimbursed or paid for by the national taxpayers will be really worth the money we are putting in. Thank you very much.